Good morning, one and all. Today we are here for our 47th webinar of IAPWC Goa. So we thought of this topic because it's such a unique topic when we go for any neurological rehabilitation of a patient. I think these are some lacunas in the rehabilitation which are never even spoken about. That is the bladder bowel and the sexual rehab of the neurological conditions that we are seeing. So we got none other than Dr. Dhara, who is going to talk to us about this topic, which is very rare. I would request Dr. Dhara to switch on the video. Yes, she is there. Without much delay, I would request Dr. Sadhvi to start with the introduction so we can get into the topic as early as possible.
Good morning, all. I'm Dr. Sadhvi Pandey. Would like to welcome you all for today's webinar that is organized by IEP Women's Cell, Goa team. Over the years, as PTs, we have treated neuro conditions, focusing mainly on their mobility and the activities of daily living. Today, we will see neuro rehab through a different perspective, including the bladder, bowel, and sexual. Today's topic for the webinar is Introduction to Bladder, Bowel, and Sexual Rehab for Neuro Conditions. And to guide us through the topic, we have Dr. Dhara Shah, who is a pelvic floor women health rehab specialist. Ma'am is a gold medalist and a PhD scholar in the topic of pelvic floor and women. Dr. Shah is a chief clinical instructor at the WOW International Institute of Pelvic Floor Research, Rehab, and Defecation.
Sorry to disturb you, but your voice is not very clear. Can you come closer to the microphone, please?
Is it audible now?
Yes.
Dr. Shah is the HOD of Pelvic Floor Rehab Clinic, which provides services to various obstetrics and gynec conditions and also for pediatric population. Dr. Shah has done research, studies, trials, and statistical analysis in areas of women health, pelvic floor rehab, including at the International Continence Society, Melbourne, Australia. Ma'am has her contributions in academics as the lead and chief assistant to Dr. H. Desai. Ma'am has also been a lead assistant and researcher for various pelvic floor rehab technologies which are under patent. For example, the Easy PFM exerciser, etc. We are pleased to welcome you, Dr. Dhara Shah, and over to you.
Thank you very much for a lovely introduction, Dr. Sadhvi. Thank you very much, IAP India, WC Goa team, and all the attendees who have joined us for this webinar on Introduction to Bladder, Bowel, and Sexual Rehab for Neurological Conditions. Now, as the title itself suggests, it is going to be an introduction because if we want to talk about bladder dysfunctions, it can be one day. If we talk about bowel dysfunction, it can be one day. And the sexual rehab, again, can be a long seminar in itself. But I would really like to emphasize on key points which we should consider and which we should understand when we are also taking care of our neurological patients. Please let me know if I am audible and I am my screen is visible to you. Anywhere, if you have any discomfort, any problem in visibility or in listening to my voice, let me know. Thank you very much. So before we go ahead with our topic, I would really like to thank Dr. Desai sir for opening our eyes about this untouched and underserved topic as pelvic floor. See, when we talk about any since before few years, when we talk about women's health, people were not understanding the concept of transvaginal, transrectal pelvic floor rehabilitation. People were just limiting themselves to antenatal and postnatal rehab cares or the the basic rehab cares which are being provided, but there was not a readiness or acceptance or awareness related to pelvic floor rehab per se. So thank you very much for sir, and it's always a proud moment for me to give an introduction of head sir. So he is the first serial innovator with multiple under patent innovations, and he's Amazon's bestseller author in neurology, Amazon's bestseller in gynecology and obstetrics, and Amazon's bestseller in physical therapy. For the work which he has done in the field of pelvic floor rehab, he is popularly known as father of modern pelvic floor rehabilitation, and it is his vision with which we are continuously working to courageously break the cultural taboo and to make the pelvic floor rehab accessible to every single woman and every single man on the globe through innovative technologies and services. So sir is also the chairman and founder of WOW IP, that is International Institute of Pelvic Floor Research, Rehab and Education. WOW Experience Research and Development, WOW Group Businesses, World Pelvic Floor Organization, and Easy PFM Exerciser. To his intellectual properties, he has PF360, VSPA, WOW Men, WOW Vagina Fit, WOW Vagina Dilate, and WOW Group mobile application. And to its academic contribution, it is HITS MMT, HITS FMT, HITS of Assessment Scale, HITS Providers Protection Guidelines, HITS Reflexive Result Scale, HITS Female Sexual Function Scale, and HITS Male Sexual Function Scale. So we do a lot of hands-on work. We do a lot of assessment things into our webinars and workshops. Many of you already know about the work which we do, the depth which we do. So not taking much of the time and going towards the major topic discussion. So I would really like to start with the prevalence of these dysfunctions, because we might be thinking that we are seeing a lot of neurological cases, but does all of them require a pelvic floor rehab, or pelvic floor rehab is limited to women's health, or say only to certain field in the rehab sector? So it is a very widely neglected area, because I'm sure you might be treating a lot of neurological patients through maybe NDT approach or any other approaches, adult neuros, pediatric neuros, and many of them would be having a pelvic floor dysfunction in the form of bowel involvement, bladder involvement, and if they are sexually active, then even a sexual dysfunction. So when we talk about the neurological conditions, it is not just limited to one condition, but it can have a lot of things into its canopy. Simple being diabetes mellitus, diabetes neuropathies, multiple sclerosis, amyotrophic lateral lesions, or myasthenia gravis, Parkinson's, space occupying lesions, hydrocephalus, traumatic brain injury, stroke, cerebral ataxia, and a lot more. So when we talk about these conditions, and when we are discussing about their activities of daily living, a simple activity like gait, balance, their sensory function, their motor function, it is very much required to even know about their bowel, bladder, and sexual dysfunction. Why? Being the statistics which are seen on your screen. So these are the studies which are being done. I have presented the references at the end of the slides. So stroke survivors, they are experiencing 28 to 79% of them, they experience urinary incontinence. So it is a very huge prevalence of urinary incontinence, and we already know that when you are seeing a patient with stroke, even if they have been discharged or they have been managed at home, they require a long-term catheterization, and which is accompanying with lot of associated risk factors to it, like urinary tract infection, chronic kidney diseases, urethral ulcerations, and a lot more. Okay. When we talk about the sexual dysfunction, so 58.6 male and 44% of females, they are suffering through sexual dysfunctions post stroke. So it's not something like that sexual dysfunctions only happen into a non-neurologically affected patients. Even a patient who is suffering through neurological because sexual behavior is a normal desire for any person. The way you have a desire to eat, desire to void, desire to defecate, you can have a desire to have in sexual intimacy, and that is not something which needs to be looked down upon. Rather, that is something where you have to take a step forward and help your patient to open up and in front of you, and then help them to manage their sexual dysfunctions as well. Okay. Many of the stroke patients, they are coming with erectile dysfunctions. Females, they are coming with then issues related to desire disorder, issues related to orgasm disorders. So there can be multifactorial involvement into it, which we would be discussing in today's session. Post-stroke, constipation, fecal incontinence, impaction of the bowel are also very frequent. When we talk about the multiples, I have tried to focus on three major dysfunctions: hemiplegia or stroke, multiple sclerosis, and spinal cord disease. But bowel bladder sexual dysfunctions are very prevalent in Parkinson's. They are very much prevalent in myasthenia gravis, or even other UMN element type of lesions like diabetes and others. But restricting the restricted time limit of 1 hour and the depth of the subject, I have tried to jot down the important points which can give you an insight that, okay, this is a field where you have to work upon and you have to explore it in more depth. The prevalence of MS is also very wide. 88% female and 86% male, they suffer from lower urinary tract symptoms. When we talk about lower urinary tract symptoms, these are like urgencies, frequencies, stress incontinence, urge incontinence, and retention of urine, residual urine. All these are the lower urinary tract symptoms. 31 to 92% male, they suffer through erectile dysfunctions, which is the commonest sexual dysfunction post MS, multiple sclerosis, and 60 post MS episodes. So it can be any type of MS. It can be a recurrent relapsing MS or a progressively growing MS, whatever type of MS you categorize them in the depth. So they all are presenting somewhere, and the dysfunctions are more in a faster progressive MS. Okay. When we talk about the spinal cord injury, no matter where is the lesion, whether it is a complete lesion or a partial lesion, whether it is a thoracolumbar lesion or a thoracic or maybe a quadra equina symptom, there is a lot of prevalence of urinary incontinence, sexual dysfunctions, fecal incontinence, and the usage of laxatives. That is the patient staying with constipation, or maybe impacted fecus, or maybe fecal retentions as well. Okay, so now when we talk about the prevalence, we have got an idea that this is not a field which needs to be overlooked. Rather, this is a field where you have to function and you have to make sure that your patients who are coming to you, they are getting a right justice, not only for the sensory and motor improvements, but even for the bowel, bladder, and the sexual improvement. So before going and understanding the pathophysiology, would like to quickly jot down the points of the anatomy of bladder. So when we talk about the bladder itself, it is a smooth muscle. It is a smooth muscle made up of by the detrusor muscle. There are three layers of bladder: the superficial, middle, and the deep layer. And it has a body. This is the body. And this is the neck of the bladder. And this is the trigone of the bladder. Okay. Now, bladder has an internal urethral sphincter and an external urethral sphincter. So it is internal urethral sphincter here and an external urethral sphincter here. Make sure that the internal urethral sphincter is involuntary. It is made up of by smooth muscles. So when we talk about it being an involuntary, that means it is not under your volitional control. The moment there is going to be a bladder contraction, the internal urethral sphincter is going to open and the urine will get collected into the urethra. Now, whether you would urinate or you will not urinate, that depends upon two things: the tone of the external urethral sphincter and your volitional control, or the presence or absence of a acceptable area. if you are driving, if you are in between, say 20 people, if you are attending a gathering and you get an urge to urinate, need not means you will urinate. Okay, why? Because of the frontal, because of the higher cortex control, because of the prefrontal cortex control, which will make sure and analyze that whether this area where you are into is acceptable area for urination or it is not acceptable area. And second is the strength of the external urethral sphincters, your pelvic floor muscles. So which has been seen into the musculoskeletal conditions like where there is a typical PFM weakness, stress urinary incontinence, where you do not want to pass the urine, but your muscles are so weak that when you cough, when you sneeze, or you get an urge, you cannot hold and you leak. Okay, so the control over the urination is majorly by the prefrontal cortex. So we'll see into the physiology of micturation. So when we talk about the physiology of micturation or neural control of micturation, we have to make sure about few things. That is, there is an area in the cortex which will be an inhibitory area, or an area which will assess that whether it is a right place to urinate or it is not a right place to urinate. So that is the first thing of the cortex to do. Then comes your pons. So Pontine micturation centers, they fall for both the way, for storage as well as for voiding. So they are medial and lateral Pontine centers, which works for storage and voiding. Now, when we talk about the Pontine centers, so from here up till, so this is the cerebral cortex, the prefrontal cortex, you can say the cingulate gyrus, and the pons, the Pontine micturation center, and then comes the role of the sympathetic and the parasympathetic outflow, and the somatic nerve supplying to the pelvic floor muscles, that is the pudendal nerve. Okay, now whenever what is the function of the sympathetic and the parasympathetic outflow here? So it is a you always remember one thing, that your urination process, it falls under the parasympathetic work. That means whenever you are urinating, at that time your parasympathetic nervous system is acting and it is allowing the process of urination. And whenever you are maintaining the continence, or there is a bladder filling phase, that is being done by the sympathetic system. Okay, and from where are these sympathetic and parasympathetic nerves coming up? So the parasympathetic supply is through the pelvic nerve S2, S3, S4, and the sympathetic nerve supply is through the thoracolumbar outflow or the hypogastric nerve T11, T12, L1, L2, L3, L4. So the thoracolumbar outflow or the sympathetic system or the hypogastric nerve will help you to collect the urine, store the urine, and to maintain continence. And the parasympathetic nerve will help you to contract and void the urine. Okay. Along with this, the major role will be of the somatic nerve fibers of the pudendal nerve arising from S2, S3, S4 as well. Okay. Here, now what happens? What is the role of the pons and what is the role of the cerebral cortex? So whenever there is in stimulation, a stretch receptors activated into the bladder, that will send a sensory stimulation to the spinal cord, which would be carried upon and relayed at the pons, and the pons will sense it and will give a signal to urinate. If you are into an appropriate place, you would urinate by the relaxation of the external urethral sphincter. Okay, so that would be again taken care by the cerebral cortex. If you are not at a proper place, then the cortex will give a signal to inhibit urination. Okay, a signal to inhibit urination. This is very important to understand the role of cortex pons in this, because when we are talking about any neurological conditions or any neurogenic bladder, we have to understand, like, depending upon the extent, the site, the location, and the chronicity of the condition, the patient might present with different forms of urinary leakage or urinary incontinence. Okay, So whether it is a cortex injury, whether it is a pons injury, whether it is supraspinal injury, or whether it is a local injury, or beneath this will give you an idea that what type of presentation the patient will come up with. Okay, so now when we are talking about this was the micturation reflex, the second comes the anatomy of bowel. Now in the anatomy of bowel also, it is very much understandable. Just zoom this slide in. So sigmoidal colon, you can say the smooth muscle sphincters, the external sphincters. Okay, so the external sphincters, they are the pelvic floor muscles, the external anal sphincters. Also here we will have one more muscle which will help us to maintain the fecal continence, that is the puborectalis muscle. Okay, and these are the internal sphincters. So these internal sphincters are again involuntary. The external sphincters, they are again voluntary in nature. Now when we talk about the defecation, what about the defecation reflex? The physiology of defecation, it is more or less the same way. The difference being the type of the dysfunction the patient is suffering through. And in the sense, whether it is, when we talk about the bowel dysfunctions, the major bowel presentations can be constipation, it can be fecal incontinence, it can be fecal impaction into the bowel and then compressing over the associated area, obstructing the associated area, and all other dysfunctions. You might have a same type of dysfunction for a Parkinson's patient and a spinal cord injury patient. In the sense, both of them can have a presentation of constipation. Okay, but in Parkinson's, the reason for constipation is different. For spinal cord injury, the reason for constipation is different. Okay, in spinal cord injury, the reason being a lesion at the spinal cord, resulting into maybe upper motor type of a neuron lesion and a inability to relax the pelvic floor and getting constipated. Whereas in Parkinson's, the pathophysiology might be a weakened abdominal muscles, rigidity of the abdominal muscles, in coordination between the pelvic floor muscles, plus the slowing and sluggishness of the intestinal content. The intestinal motility also decreases. Okay, so your plan of care would change depending upon the basic etiopathology of the condition, of the neurological condition you are seeing. Maybe in Parkinson's patient, you can plan a care into the drug on time, and maybe into a a SI like spinal cord injury patient, you can plan your rehab section when the bladder is empty. Maybe you might the bowel is empty or the bladder is empty, maybe by using a suppository or a catheter, because of the risk of autonomic dysreflexia, which we would be discussing once we are going ahead. So that was the physiology of defecation. This is the basic physiology of defecation and micturation. Coming towards the sexual functioning, see, we are bladder or bowel impaction or catheterization is still something which has been discussed or the patient knows about it, but a sexual dysfunction is very widely ignored. Thinking about, like, the patient might not be willing to come up and speak about the sexual dysfunction with the fear of being judged. What if I go and tell my doctor or my rehab professional that I'm having a sexual dysfunction, and what if they mock around me, or what if my family would not support me, my wife would not support me, or my husband would not support me? So a sexual, and it is not so that the neurological conditions, if they are happening at an older age, and by that time the sexual functioning is as such reduced. It is absolutely not so. Okay, depends upon what was the patient's, like, she's 50 years old suffering through Parkinson's since maybe an early onset of Parkinson's genetic types of, or maybe due to any other reason suffering it since 1 year now, and before that her sexual life was really very active, and since there is an Parkinson's dysfunction, she is unable to get into a sexual activity. Okay, or 30-year-old patient suffered through a hemorrhagic type of a stroke or a head injury, and after that is suffering through erectile dysfunction. So so in this particular cases, it's not so. Or a meningomyelocele patient, a patient suffering through a meningomyelocele, a patient suffering through transverse myelitis or multiple sclerosis with an early onset of age. Okay. So in these cases also, the sexual dysfunctions can be very much prevalent. And when we talk about their prevalence in male, the most common found is erectile dysfunction, followed by premature ejaculation. And in female, it is dryness, like vaginal dryness. It can be reduced desire to have sex and an orgasmic dysfunctions. Now, this is a basic, we know that this is the female erogenous structure, which is clitoris. You can see this as the shaft of clitoris, the glands of clitoris, the legs of clitoris, and these are the vestibular glands or the vestibular bulbs, the urethral opening and the vaginal opening. So this is a basic structure of clitoris. Again, I'm not talking about the detailed of labia majora, minora, G-spot, what does the cervix do, and the breast tissues and all, but this is a basic erogenous structure for a female. And this is a male penis, okay, which is responsible for the sexual activity. Now, when we talk about the sexual activity, it is not just the perineal area, or it is not just the clitoris or the penis or the spinal cord which is working into it. There is lot more of a complex mechanism happening at the brain level as well. So if we talk about the sexual areas of brain, or the areas which control the sexual desire, the sexual drive, the attraction, the memory, the response, it is all about these many areas and many more. So when we talk of every area which I have mentioned here, the thalamus, the amygdala, the prefrontal cortex, the cingulate gyrus, the insula, the reward system, the hippocampus, the hypothalamus, and the septal nucleus, all of them, they have different, distinct, precise, yet correlating activities. Okay, like your prefrontal cortex will work for cognitive filtering. Okay, your amygdala will work for the maybe the experience. Okay, your hippocampus would work, maybe working for your memories, like what memory did you had in the past and how are you behaving right now. Okay, maybe your reward system is the first system which will initiate, or which will give you an idea of how you have to respond for an sexual stimulus. So there is a very complex phenomenon which happens into the brain. So whenever there is a first, maybe a fantasizing thought, or a visual, or an auditory, or maybe a physiological touch, so with that there is lot of changes which happens in all these areas. And finally, like again, the cortex will control whether you will proceed or you will not proceed into that direction. And then comes the role of the again the sympathetic and the parasympathetic nervous system, along with the pudendal nerve. Okay, so this is a complex physiology, or a brain physiology. And here I would really, you might think that why would it be important for us to know about this? So just a short case study, which is like a very old one, dated 1944, or maybe older than that, when the sexual dysfunctions or these conditions were not been addressed the way they are being addressed now, rather it was not been discussed ever. So a doctor met a female of 43 years old with an complaint of repeated sexual desires, and the desires were so instinct, the desires were so, you know, those desires were so instinctive and of such a high amplitude that she had to go for an sexual activity. Okay, she had to participate into an activity. So so the doctor thought that she might be having a nymphomania. Nymphomania means addictive behavior towards an sexual activity, increased sexual desire, and can have multiple partners to fulfill the desire. So she was being treated in the form of, like, the doctor thought that Erickson, maybe Dr. Erickson is the right name. You might find these articles also. It is a very well published articles in the journals of neurology. So when the doctor, he thought that it might be because of ovarian hormone excessive secretions through the ovarian hormone. So he decided to burst the ovaries with X-ray, and even after bursting the ovaries with X-ray, she kept on getting those sensations again and again, and the frequency, the intensity, and the repetitiveness increased so much that it was then followed up with an epileptic shock. So she had to get intimate, she had to get into a sexual activity, and then she was ending up being unconscious or forgetting about the incidents completely. And when she came back again at an age of 54, at that time they thought that it might not be the the local system, it might be the higher cortex. They ultimately opened the brain, they saw that what is the dysfunction over here, and they found a significant growth over the temporal lobe, which was compressing the temporal lobe, and that was the reason for epilepsies and a sexual behavior. So they operated her, and then after that she did not have any episodes of a sexual desire. Okay, so my point, what I want to convey here is, it's not always about just a psychological thought or maybe a stimulation by a partner or your need. It is really more complex behavior of your brain. And now with this, you can understand that if there is a patient who is suffering through stroke or multiple sclerosis or traumatic brain injuries or any other condition where there is a specific involvement of any of these areas, they can present with, or maybe a spinal cord tract injury, spinal cord injury, they can present with a varied dysfunctions into the sexual behavior as well. They can have an increased sexual drive, they can have a reduced sexual drive, they can even experience a difficulty with penetration and all these things. So when we typically talk about the sexual behavior, want to make sure one thing, that if the female is into her reproductive age, then her potency to reproduce maintains. She is reproductive at that time as well. If she's suffering from, say through SCI, spinal cord injury, then also there are chances that she may conceive because her reproductive system is active. Okay, so 23 years old female, 25 years old female, 30 years old female suffering through transverse myelitis or say spinal cord injury and wants to conceive, but that is possible. But the thing which we have to understand is, it's not the reproducibility of the female, it's about the sexual dysfunction or the sexual behavior which can ultimately lead to a reproduction which is involved. Okay, so and that is a very bad scenario, that you are menstruating regularly, you want to conceive, but there are some limitations with your sexual behaviors through which you are unable to get into this. So normal sexual response cycle, will quickly go through this, is divided into the phase of desire, arousal, orgasm, and resolution. So desire is the first thought, arousal is the response of the body towards that, the physiological response of the body towards that stimulus. Orgasm is the feeling or the highest state of satiety for a male as well as a female. In male, it is followed by ejaculation, and then comes the phase of resolution, when all the changes which has happened into your body, they come back to the baseline tone. That is the phase of a resolution. So these are the basic levels of the sexual response cycle. And then going towards the neurogenic bladder. So when we talk about the neurogenic bladder, depending upon the level of injury, the patient might have a presentation. Again, it's not just always the level of injury, it is the level of injury, the extent of injury, the chronicity of injury, and whether there is any predisposing condition prior to injury. Okay, so would like to speak this sentence again, that whenever you are evaluating any patient with a neurological bladder or a neurological bowel, you need to understand that it is not always about the extent of the site of injury. It is the site of injury, the extent of injury, the chronicity of injury, and a predisposing factor prior to injury. Okay, so depending upon that, your diagnosis might alter and your treatment plan might alter. Now, coming to the neurogenic bladder, we can divide the neurogenic bladder into four different types. So those are the uninhibited, the automatic, the autonomous, and the overflow. So when we say the uninhibited, so uninhibited means if there is a cortical injury, if there is an injury to the cortex, okay, or maybe a stroke involving the cortical region, okay. So at that time, your higher control over the bladder is lost. So you can like imagine a classroom without a teacher. Okay, everything is haywired here and there. Fine. So at that time, when your cortex is not functioning, your cortex is not present, or it's inhibited. So what it will do? What is the role of cortex? The role of cortex is to decide when to urinate and when not to urinate. Okay, so it has an inhibitory, or you can say it has a filtering role rather. Okay, so if that is lost, what will happen? Your bladder will become an uninhibited bladder. Uninhibited bladder means it will full, it will empty, it will full on its own, and it will empty on its own. Okay, so the person will have no control over his or her bladder, and this is a case which might be present at a very early stage of a cerebral shock or a traumatic brain injury, or maybe a more advanced stage where the person ends up into when there is a complete loss of the cerebral tone. So typically the role of care would be a indwelling catheterization, because the patients who are coming with an uninhibited bladder would have a lot of a neurological or a cortical level involvement as well. They might be either into comas, ICUs, or hospital management or home-based plan. So that is an in uninhibited bladder, or constantly like there is no control at all. So it can, like, once the patient is coming out of shock or there is an improvement slowly, once the peripheral tone. So basically, when we talk about the neurogenic bladder, you can easily understand the bladder considering the type of the injuries, whether it is an upper motor neuron lesion or a lower motor neuron lesion. If it is an upper motor neuron lesion, so we will that similar picture can present into the bladder or the bowel also. So immediate stage of shock, when you say areflexia, so uninhibited bladder. And once you are getting the tone back of your maybe peripheral joints, your other skeletal joints, similarly you are getting the strength, or you're getting the perception of the bladder back again. I would like to mention one thing over here is, if there is an indwelling catheter, or if there is a catheter in situ, we are not supposed to go for pelvic floor exercises, pelvic floor contractions, according to the reference through UCLA. Okay, because there are chances that with this urethral catheterization or indwelling catheterization, if you go for pelvic floor exercises, it might damage your urethral structures or the surrounding areas. Okay, or it can even affect the normal urinary functionings. Okay, so that's why whenever there is an indwelling catheter, we are not supposed to go for pelvic floor rehab at that particular point of time. So it starts once the catheter has been removed. So many patients okay, let's not go into that. Let's finish with this first. Then comes the automatic bladder. So as the name suggests, automatic. It will work upon its own. So now if there is a cortical injury, it can be an uninhibited. If it is an if there is any injury which is through from the at a supraspinal level, in the sense from the pons to the spinal cord level. So if there is like conus medullaris, if there is any injury into this, it can be an automatic bladder. Automatic bladder in the sense the bladder would fulfill on its own, and it will contract and you will urinate. Okay, now in automatic also there can be two presentations. So it can be an automatic bladder, that is hyperreflexive detrusor within coordinated PFM, or it can be an automatic bladder without a PFM coordination. So it can be a detrusor dyssynergia, okay, or detrusor PFM dyssynergia. So where the functioning of these muscles are being altered. So there is a contraction of the detrusor followed with a relaxation of PFM. So that is automatic. Maybe the patient will have multiple urges a day and she might be able to empty her bladder completely with every urge. That is automatic. Or it can be a different presentation, which is the detrusor dyssynergia, where there are chances that the patient might get a strong urge, but simultaneously the PFM would not relax. And that can lead to a retention of urine or residual urine filling, and then it can lead to further complications of chronic diseases or chronic dysfunctions. Okay, so that was two types of automatic. Then is autonomous. Autonomous means now it is like a type of an injury at the level of the either the level or below the level of the conus medullaris, your sacral reflexes. So it is a type of a lower motor neuron lesion where there will be a difficulty in emptying. So where then there will be a difficulty in emptying means the bladder will fill, and it will not be, so it will not empty. It will be presenting like that of a flaccid bladder. So flaccid bladder means filling will happen, and ultimately the patient might have dribblings. Okay, it might, she might dribble down. So that can be a autonomous bladder, or it can be an overflow. So again, overflow is like autonomous only. Sometimes maybe a local neuropathic injury leading to an diabetic involvement, or you can say a herpes zoster involvement, or a local neuropathic condition can result into an overflow. But it's more or less same, that there is a flaccid bladder which fills, and then, so this is an uninhibited bladder, this is a spastic bladder, this is a flaccid bladder. Okay, so that is the basic type of a neurogenic bladder. And coming to the neurogenic bowel. So when we talk about the neurogenic bowel, it can be a constipation. Patient is unable to defecate, a constipation, because of the lack of the rectal stimulations, also, or rectal receptor, rectal desensitization, or reduced sensations of the rectal receptors. Or it can be a fecal incontinence, or it can be a pelvic dyssynergia, as we discussed in the case of a bladder. So more or less, these both, like bladder dysfunctions, are not that quite common compared to a bowel dysfunction. So bladder, most common would be constipated bladders, constipated bowel. So bowel dysfunction is not, it's not uncommon, but it is not that common as like that of a bladder dysfunction. Okay, so and now not going into the sexual dysfunction in detail, because if we talk about sexual dysfunction, depending upon the cycle which is involved, whether like depending upon the area which is involved, the patient might have a presentation into their sexual behaviors, or they might have a presentation into their sexual responses. So they can have the most common being the dryness of the vagina, dyspareunia, or so flaccid desire disorder, or an arousal disorder. So these are orgasmic disorder. So these are the types of this would be the basic differentiating. Now if you think about a patient who is suffering through Parkinson's dysfunction. Okay, so in Parkinson's dysfunction, maybe the arcs are not involved, but the basic Parkinson's pathology, which causes bradykinesia, rigidity, slowness of the movement, and sluggish movement of even the intestines as well as the abdominal muscles, that can result into constipation, compared to the constipation occurring due to spinal cord injury. Okay, so if you're treating a patient with Parkinson's cases, you might start the treatment, you might work upon the abdominal areas also, you might work upon the the gut motility and all these things, which might be different from that of the spinal cord injury, or the patients who are suffering through stroke or multiple sclerosis, where maybe the presentation is similar, but the causative etiology or the causative factors are different. So when we are talking about the pelvic floor assessment, or pelvic floor rehabilitation. So we have to make sure that we do not forget upon the major assessment things, like you do a sensory assessment, you do a motor assessment, you do a gait assessment, you fill the questionnaires to make sure that whether the patient actually requires a pelvic floor rehab or they do not require, like if it is an uninhibited bladder, maybe you have to get them first to a level where they are at least not on a indwelling catheter, they are on an intermittent catheter. Okay, so you have to rule out that whether they fit into the category or they do not. So by doing the assessment, like we would not be discussing the assessment in detail, um, but the simple assessment scale which can be done in order to find out the pelvic floor, because how would you plan the rehab? If you are seeing the patient with a transversus myelitis suffering through 17 years, suffering from 17 years, okay, coming up with a weakness of lower limb, how would you plan a management for her? For that, you have to first evaluate that what is the level of PFM involvement. The PFM is having what level of involvement, and after that, what is the behavior? What is her pattern? What is her bowel habits? Because after that only you can plan a management. So a simple tool to assess the PFM muscle dysfunction. So a scale which was being used, modified Oxford grades, but the limitations, as we all know, cannot measure the relaxation of the pelvic floor muscles and cannot give a exact idea to what the grade is. So it is quite subjective and not quite vague and not specific. So these two limitations are being taken care by Hates MMT, where I really would require I would really request all the neuro PTs who are here, who are working into the neurological segments or sectors. I would really like that you understand the scale and you can really use it for your patients who are suffering through a neurological dysfunction. So you can assess your PFM muscles, like 0 being the baseline tone, where there is no, this scale Hates MMT is being developed by Dr. Hate Desai sir, and it is being accepted worldwide because it has bridged the limitations of modified Oxford. Hates MMT measures the relaxation component as well as it measures it gives you a specific idea about the weakness and the of the pelvic floor muscles. So this scale has been innovated by Hetzer with lots of intelligence and years of practice. So 0 being the baseline tone. Okay, if when you are going for a transvaginal examination of pelvic floor muscles, if the patient is not allowing you to penetrate, there is pain, there is tightness, there is discomfort, and patient is not allowing you to penetrate. So it is -1 inability to penetrate. -2 is symptomatic penetration. So penetration is there, but it is with symptoms of pain, tightness or discomfort. That is -2. And -3 is an asymptomatic relaxation. So when you ask the patient to relax, she's relaxed, you can go in and out. So that is -3, that is asymptomatic penetration or an easy penetration. So -1 means inability to penetrate, no penetration at all. -2 means a symptomatic penetration. It can be pain, tightness, or discomfort, or any other symptoms, which is not giving you an easy penetration. Okay, and -3 is an easy or an asymptomatic penetration. When you check about the strength component, so 1. So if once you are inside and you ask the patient to squeeze, and when the patient is squeezing, you can feel a mild contraction from any one side. Okay, a mild contraction from any one side is grade 1. A complete circumferential grip is grade 2. A complete circumferential grip is grade 2. And then strong upwards and inwards pull against resistance is grade 3. So quickly going through this scale once again. 0 is the baseline tone. -1 is inability to penetrate. -2 is asymptomatic penetration. -1 is inability to penetrate, no penetration at all. -2 is symptomatic penetration, where there is a symptom of pain, tightness, or discomfort, a symptomatic penetration. And -3 is an asymptomatic or an easy penetration. Okay, so that means it is a complete relaxation. Once inside, you squeeze the patient You squeeze the patient, and if the patient will give you a mild contraction from any side, that is grade 1. A complete circumferential grip is grade 2, and a strong and upwards pull against resistance is grade 3. So this is a simple, there are a lot of pelvic floor examinations which is required, uroflowmetry which is required, defectogram which is required to check upon the different aspects of bowel bladder dysfunctions. You need to assess the strength and all these things, but this is a basic or at least a bare minimum tool which will help you to differentiate your patients. And when we talk about the management, so I was talking about the management. So when we typically talk about the neurogenic bladders or bowels, it has to be a holistic approach. In the sense, suppose if there is excessive detrusor overactivity, or if there is excessive detrusor contraction, maybe because of UMN lesion, you might have to give them certain drugs which will inhibit the detrusor. So detrusor relaxant drugs are also required, which comes under the pharmacokinetic therapy. So that requires a urologist or a neurologist to give that. Along with that will come the basic, even the surgical. At times, if the patient is on an uninhibited bladder for a long period of time and is unable to gain strength back or unable to get the sensations back, they might have to go for a suprapubic catheterization, okay, or maybe a bladder myectomy, or maybe increase, going for any bladder surgeries or a bowel surgeries which are required. So that follows the surgical interventions. When we talk about the conservatives or the pelvic floor rehab, so the basic conservative what we was being used, like catheters. So when we talk about the catheters, as I said, that whenever there is an indwelling catheter, we should not go for pelvic floor exercise, for pelvic floor rehabilitation at that point of time. We have to wait till the time it becomes a intermittent catheterization. So how is the intermittent catheterization is being planned? Okay, whenever a patient is on a is suffering through a neurological dysfunction and they are on catheters, it is not been removed in one day. They generally give the catheter trials, in the sense they will clamp the catheter for certain times and then they will ask the patient to get the sensation. So the moment they get the sensations, they will unclamp and they will allow the urine to pass. Why is this required, the clamping and unclamping? Because when the catheter is there, it is present, the patient will not have any urinary sensations. Why? Because the bladder is not getting full. Every time there is a urine, it will come out. The urine will come out. So there is no fulling, there is no stretch receptors activity. So you clamp the catheter, you keep like that, and then you allow the bladder to stretch and check for the perception of the patient, whether the patient gets a perception or not. Once they get a perception, then you open the kink and you allow them to urinate. And the next goal would be to slowly increase the level of clamping. So first you clamped for 1 hour, then you are clamping for 2 hours. So slowly you are increasing the clamping time. So you are taking the patient from on catheter to off catheter progressively. And once the patient is, your ultimate goal is to bring them off the catheter, okay, or at least to a level where they can go for a self catheterization. If it is an hypotonous type of a bladder, say if it is a bladder which is autonomous, okay, so then you need a manual pressure from the abdomen. You have to apply a manual pressure and evacuate the bladder. Suppose if, or you can use a Creed's maneuver, like pressing over the suprapubic area, increasing the pressure and then voiding, okay. Or if it is a spastic bladder, so that spastic bladder or a hyperreflexive bladder can work with a minimal stimulation, like a tactile stimulation, a touch or pricking of the hair, or just tapping. So that's how you can help them manage their bladders, okay. So if in case, if you are seeing a patient with a catheter in situ, so right from the catheter in situ, you have to bring him to intermittent catheterization, then no catheter, or maybe a self catheter. So self catheter, again, there are lots of pros and cons for self catheters also, but like the commonest use is K90. It can lead to urethral ulcerations and other UTIs and all those things. But till the time the patient does not develop a self-voiding that is required. So then how to manage those will also play a role. And once it is off catheter, there comes your pelvic floor rehab. So it depending upon the type of lesion, and the same thing, and the complaint of the patient, you can plan your you can plan your pelvic floor sessions, like whether the patient would need a strengthening of pelvic floor muscles, or they would need a relaxation of pelvic floor muscles, or they would need a synergic pattern to be developed for their pelvic floor muscles. So uh, depending upon these conditions, like what is your diagnosis, we can, if it is weak, we need to strengthen the muscles. If it comes out to be tight, we have to relax the muscles. And if you find it is dyssynergic, you have to increase the coordination of your muscles. So depending upon the type of presentation, you have to plan your treatment. Because of just 1 hour and such a long topic, I think that I was able to give you at least an insight of what management should be followed and how it should be done. If you are really interested to work into this field, and you really want to know in detail about the rehab sections, then our next workshop, our next webinar would be on pelvic floor rehab for neurological conditions. You can directly contact me on my WhatsApp number to know more details about it, 8005215003, or you can mail me on cci.wowipri@gmail.com as well. We'll write those mail IDs and the phone numbers in the chat box. And giving you these are my references which had been used. And just a short introduction of WOW IPRI, that is International Institute of Pelvic Floor Research, Rehab and Education. It is founded and led by Dr. Hed Desai sir, who is a very much visionary, innovative, and a great leader himself. WOW IPRI has received certificate of recognition for Government of India to provide specialized training to perform transvaginal transrectal pelvic floor rehab, to place skilled pelvic floor specialists, to gynecology, urogynecology, and neurologists, to develop the franchisee also in domestic as well as international market, to carry on same activity and to create win-win situation, as it will benefit millions of patients. Now, not just pelvic floor, the neurological patients, the patients suffering through other dysfunctions as well, and to give them a specialized care, to benefit doctors, hospitals by creating more revenue and multiple jobs, to offer innovative business model, to offer unique services, to bridge the gap between the patients and the specialist with simple but highly efficient business plan, and improve patients' health, well-being, and doctors' business and services. We are a global brand now, training in 13 different countries. Sir's book, that is its Manual of Pelvic Floor Rehabilitation, is Amazon's bestseller. So has multiple contributions which already had discussed. The book has been restored multiple national and international dignitaries and their endorsements. And he has different this is about it. One thing, thank you very much from me as well as from Hed sir for joining this war against silent suffering and working into this field. One thing which is very important when we talk about the bowel bladder dysfunctions is maintenance of bladder diary. And typically here in this case, maintenance of the diary with the input, the time of input, the quantity of input, output, and episodes associated with output. So what did you have, in what quantity did you have, and when did you have? That is input. When did you evacuate? What quantity did you evacuate? That is output, and an associated factor to it. So whether it was associated with a emotional anxiety and associated with a urinary incontinence, or like a stress incontinence, an urge incontinence, or an urgency. So depending upon that, because it's not just about the neurology, it is also about the biopsychosocial behavior. So in a meningomyelocele case, or a Parkinson's case, or maybe any neurological case, where the depression component is higher compared to the normal individuals, there are chances that if they are listening to any sad news, or any emotionally disturbing news, their bladder might react, their bowel might react. So this will help you, knowing about these involvements as well, will help you to plan a home exercise care. It will help you to realize that whether do they need a cognitive rehab along with the pelvic floor rehab. So not just input and output, but an input and output and associated factor and a triggering factor to it would be required to develop a long-term plan for the patients with a bowel and bladder dysfunctions, specifically into neurological conditions. So thank you very much for listening to me, and thank you once again from me, from our whole WOW team and Dr. Hedesai sir for taking a step forward and breaking this cultural taboo. Thank you, Dr. Smarnika, for organizing a wonderful webinar. IAP India, IAP Women's Cell, Dr. Ruchi Vashne, Dr. Sanjeev Jha sir, and one and all, thank you very much.
Thank you, Dr. Dhara.
Dr. Mamta, please take over.
Yeah, thank you, Dr. Dhara. So a few participants wanted to know that if there are any questionnaires on pelvic floor rehab.
Yeah, there are many questionnaires which are available for pelvic floor rehab. I would share those questionnaires into the group. If there is pelvic floor inventory, when inventories are available, quality of life affecting with the stress incontinence is available, HATES female sexual function scale and male sexual function scale for specifically assessing the sexual dysfunctions is available. The bowel inventory is available. So you can, we have a group on the WhatsApp. You can join us on that group, or you can personally message me on my WhatsApp number so that I can share those material. Otherwise, also these are available on Google, the pelvic floor inventory questionnaires or the pelvic floor distress questionnaires, the stress urinary incontinence and quality of life questionnaires. So these are available as I mentioned. Do we have any other question?
Okay, thank you, Dr. Dhara. So does anybody have any more questions to ask? So let me thank Dr. Dhara for this presentation. It was very, very informative. I want to also thank our IAPWC Central team for this platform, our IAPWC Goa committee members for their time, for their effort, and special thanks to all our attendees for giving your time and day. Hope you all have a wonderful day ahead.
Thank you very much. I'm just writing my phone number. If someone wants to connect, they can connect with me.
Dr. Smani.
Thank you all for your time. With this, we would have come to an end to the session. So thank you for all the attendees. You can take the contact details from Dr. Dhara and contact her regarding the topic and the coming webinars.